What do you see in this image? Here we have an interesting case. I'm seeing inferomedial subcoracoid displacement of the humeral head with too much overlap of the humeral head and bony glenoid. This pattern is quite classic for an anterior shoulder dislocation. Differential diagnoses include none, as this is an Aunt Minnie. To further evaluate, an axillary view is diagnostic and can show associated hill sacks and Bankart lesions. Management typically involves closed reduction under sedation, followed by immobilization and physical therapy. Let's move on to the next case. What abnormalities can you identify in this image? Here we see lateral displacement of the humeral head with the empty glenoid sign. This is indicative of a posterior shoulder dislocation. Differential diagnoses include none, as it's another Aunt Minnie. Axillary and transscapular Y views are diagnostic and can show the trough sign and posterior bony glenoid impaction. To further evaluate, these additional views are essential. Management usually involves closed reduction, but in chronic cases, surgical intervention may be required. What do you notice in this image? This image shows an asymmetric appearance of the sternoclavicular joints, with the medial portion of the left clavicle looking abnormal. This is suggestive of a sternoclavicular dislocation. Differential diagnoses include an occult fracture of the sternum or medial clavicle. To further evaluate, a CT scan is necessary to evaluate the great vessels and mediastinum. Management typically involves closed reduction or surgical repair, depending on the severity of the dislocation and associated injuries. Let's move to the next case. What could be causing this image? In this image, we see a fracture of the radial styloid, scaphoid, and ulnar styloid with posterior dislocation of the capitellum. This is characteristic of a transscaphoid paralunate dislocation. Differential diagnoses include none, as it's an Aunt Minnie. To further evaluate, additional wrist views are helpful to assess the extent of injury. Management involves surgical fixation to stabilize the fractures and dislocation. What do you notice in this image? This image shows disruption of the proximal carpal row with a pie-shaped lunate. This is indicative of a lunate dislocation. Differential diagnoses include none, as it's another Aunt Minnie. A lateral view is diagnostic for confirming the lunate dislocation. Management involves closed reduction followed by immobilization, and surgical intervention may be necessary if closed reduction fails. Let's move to the next case. What abnormalities do you notice in this image? This image shows cortical irregularity of the lateral talar dome with bony fragments in the lateral mortise and widening of the distal tibiofibular syndesmosis. This is indicative of a talar osteochondral fracture. Differential diagnoses include none, as it's an Aunt Minnie. To further evaluate, an MRI can help assess the extent of the osteochondral injury. Management involves immobilization and possibly arthroscopic surgery to remove loose fragments and repair the defect. What do you see in this image? Here we have lateral dislocation of the 1st through 5th metatarsals at the Lisfranc joints. This is indicative of a homolateral Lisfranc fracture dislocation. Differential diagnoses include none, as it's an Aunt Minnie. To further evaluate, weight-bearing radiographs or a CT scan can provide a better assessment of the Lisfranc injury. Management typically involves surgical fixation to stabilize the dislocated joints. Let's move to the next case. What abnormalities do you notice in this image? This image shows destruction, debris, dislocation, and increased density of the Lisfranc joints with pes planus and vascular calcifications indicative of diabetes. This pattern is characteristic of diabetic Charcot foot with Lisfranc fracture dislocations. Differential diagnoses include osteomyelitis. To further evaluate, an MRI can help differentiate between Charcot arthropathy and osteomyelitis. Management involves offloading and immobilization, and surgical intervention may be needed in severe cases. What do you see in this image? This image shows a horizontal fracture at the base of the great toe distal phalanx. This appearance is indicative of a nail bed injury. Differential diagnoses include none, as it's an Aunt Minnie. To further evaluate, an X-ray of the toe can help assess the extent of the fracture. Management involves treating it as an open fracture with a high incidence of osteomyelitis, requiring antibiotics and possibly surgical debridement. Let's move to the next case. What abnormalities do you notice in this image? This image shows a lucent lesion in the medullary space of the distal humeral diaphysis with cortical scalloping and periosteal reaction. This is indicative of a pathologic fracture. Differential diagnoses include none, as it's an ant mini. To further evaluate, an MRI can help assess the lesion's nature and extent. Management typically involves treating the underlying cause of the pathologic fracture, which may include surgical stabilization, and addressing any associated neoplastic or infectious process. What do you see in this image? Here I have a diffuse permeative lesion of the proximal femur. This pattern is quite classic for lymphoma. I can see the extensive bone destruction with a moth-eaten appearance, which is common in aggressive lesions. Differential diagnoses include metastases, multiple myeloma, osteomyelitis, and Langerhans cell histiocytosis in pediatrics. To further evaluate, I should perform an MRI to assess the extent of marrow involvement and a biopsy to confirm the diagnosis. Management usually involves chemotherapy and sometimes radiation therapy, depending on the stage of the disease. Let's move to the next case. What abnormalities can you identify in this image? Here I see a sunburst periosteal reaction of the distal fibular diaphysis. This is indicative of Ewing's sarcoma. Differential diagnoses include osteosarcoma, which also shows aggressive periosteal reaction, but may have more of a Codman's triangle appearance, osteomyelitis, which would have signs of infection, and Langerhans cell histiocytosis, typically seen in younger patients. To further evaluate, an MRI of the affected area is necessary to assess the local extent of the tumor and involvement of surrounding tissues. A biopsy is also essential to confirm the diagnosis. Management involves a combination of chemotherapy, surgery, and possibly radiation therapy. Let's move to the next case. What do you notice in this image? This image shows L5 disc space and adjacent end plate sclerosis and destruction with about 50% aneurysthesis and gibbous deformity. These findings are characteristic of Dasov disc osteomyelitis, with the narrowing of the disc space and irregularity of the end plates. There are no differential diagnoses here. It's an ant mini. To further evaluate, an MRI is necessary to assess the extent of the infection and any involvement of surrounding structures, including possible abscess formation. Management typically involves long-term intravenous antibiotics and possibly surgical intervention to stabilize the spine and drain any abscesses. Let's move to the next case. What could be causing this image? In this image, I see joint space narrowing, rat bite, marginal erosions, and no new bone formation with soft tissue swelling. These findings are classic for rheumatoid arthritis. The erosions are particularly notable at the joint margins where the synovium invades the bone. Differential diagnoses include gout, which typically has more punched-out erosions, and tophi, septic arthritis, which would present acutely with severe pain and infection signs, and psoriasis, which may have pencil-in cup deformities. To further evaluate, additional imaging such as MRI or ultrasound can help assess the extent of joint involvement and guide management. Management involves anti-inflammatory medications, disease-modifying anti-rheumatic drugs, DMARDs, and biologic agents. Let's move to the next case. What do you notice in this image? This image shows an increased distance from the medial femoral head to the teardrop, known as the teardrop distance. This is indicative of right hip septic arthritis. I can see the widening of the joint space due to effusion. Differential diagnoses include a septic joint effusion, synovitis, and hematoma. To further evaluate, an ultrasound-guided aspiration of the joint fluid is necessary to confirm the diagnosis and identify the causative organism. Management involves intravenous antibiotics and possibly surgical drainage if there is no response to medical treatment. Let's move to the next case. What abnormalities do you notice in this image? This image shows a 2 mm lucency surrounding the fixation hardware and screws. This finding is suggestive of a hardware infection. I can see the radiolucent halo around the hardware indicating loosening due to infection. Differential diagnoses include hardware loosening without infection. To further evaluate, an MRI with metal artifact reduction sequences can help assess the extent of the infection. Management involves removal of the infected hardware and prolonged antibiotic therapy. Surgical debridement may also be necessary to eradicate the infection. Let's move to the next case. What do you see in this image? Here I have soft tissue swelling and gas overlying the wrist and proximal hand, along with vascular calcifications indicating diabetes. This is characteristic of necrotizing fasciitis. The presence of gas within the soft tissues is a critical finding. Differential diagnoses include post-traumatic soft tissue gas. To further evaluate, a CT scan can help assess the extent of gas formation and involvement of deep tissues. Management involves urgent surgical debridement, broad-spectrum intravenous antibiotics, and supportive care. Let's move to the next case. What abnormalities do you notice in this image? This image shows right sacroiliac joint fusion with symmetric hip joint narrowing. These findings suggest asymmetric sacroiliitis, which could be due to Reiter syndrome, psoriatic arthritis, or infection if asymmetric, and inflammatory bowel disease or ankylosing spondylitis if symmetric. To further evaluate, an MRI of the sacroiliac joints can help assess the extent of inflammation. Management involves anti-inflammatory medications and treating the underlying cause, such as antibiotics for infection or DMARDs for inflammatory conditions. Let's move to the next case. What do you see in this image? This image shows symmetric sacroiliac joint erosion and subchondral sclerosis, along with a mildly dilated ahaustral ascending colon. This is indicative of symmetric sacroiliitis associated with ulcerative colitis. The combination of bowel and joint involvement points to this diagnosis. No differential diagnosis is needed here. It's another Aunt Minnie. To further evaluate, a colonoscopy with biopsy is necessary to assess the extent of colitis. Management involves anti-inflammatory medications, immunosuppressants, and possibly surgery for severe cases of colitis. Let's move to the next case. What abnormalities do you notice in this image? This image shows large erosions with overhanging margins at the great toe metatarsophalangeal MTP joint, dense periarticular swelling, and sparing of the joint space. These findings are characteristic of gout. The rat bite erosions and periarticular swelling are key features. No differential diagnosis is needed here. It's an Aunt Minnie. To further evaluate, serum uric acid levels can be measured, and a joint fluid analysis can confirm the presence of urate crystals. Management involves anti-inflammatory medications, urate-lowering therapy, and lifestyle modifications to prevent flare-ups. What do you see in this image? Here I see bilateral wrist and first-third MCP joint space narrowing with small hook-like osteophytes of the metacarpal heads and chondrocalcinosis of the wrist. These findings are characteristic of calcium pyrophosphate dihydrate deposition disease, CPPD. Differential diagnoses include hemochromatosis, which also presents with chondrocalcinosis, and hook-like osteophytes. To further evaluate, I would recommend serum iron studies to check for hemochromatosis. Management involves treating any underlying metabolic disorders and symptomatic treatment with NSAIDs or colchicine. Let's move to the next case. What abnormalities do you notice in this image? This image shows erosion and resorption of digital tufts, osteopenia with coarse trabecula, and subperiosteal bone resorption along the radial side. These findings are indicative of hyperparathyroidism with acroosteolysis. Differential diagnoses for acroosteolysis include frostbite, electrical burn, polyvinyl chloride exposure, pycnodicystosis, neuropathy, psoriatic arthritis, and Haudou-Cheney syndrome. To further evaluate, I would perform a serum parathyroid hormone PTH level test to confirm hyperparathyroidism. Management involves addressing the underlying hyperparathyroidism, often with surgical removal of the overactive parathyroid glands. Let's move to the next case. What do you see in this image? This image shows trabecular rarefication within the central vertebral bodies and increased sclerosis of the end plates, known as the Rugger-Jersey spine. This is characteristic of renal osteodystrophy. No differential diagnosis is needed here. It's an Aunt Minnie. To further evaluate, a bone biopsy can confirm the diagnosis, but usually the clinical context of chronic kidney disease suffices. Management involves treating the underlying kidney disease, often with phosphate binders, vitamin D analogs, and dialysis. Let's move to the next case. What abnormalities do you notice in this image? Here, I see a round lucent lesion in the proximal great toe phalanx, osteopenia, marginal erosions, and vascular calcifications. These findings are indicative of hyperparathyroidism with brown tumor. Differential diagnoses include enchondroma, fibrous dysplasia, and Brody's abscess. To further evaluate, I would recommend a serum PTH level test to confirm hyperparathyroidism. Management involves treating the underlying hyperparathyroidism, which may include surgical removal of the parathyroid adenoma or hyperplasia. Let's move to the next case. What do you see in this image? This image shows abnormal soft tissue calcifications in the anterior pelvis and vascular calcifications. These findings suggest hyperparathyroidism with dystrophic soft tissue calcifications. Differential diagnoses include tumoral calcinosis and myositis ossificans progressiva. To further evaluate, I would perform serum calcium and phosphorus level tests to assess for hyperparathyroidism. Management involves treating the underlying hyperparathyroidism and symptomatic management of the soft tissue calcifications. Let's move to the next case. What abnormalities do you notice in this image? This image shows osteopenia, fuzzy trabecula, erosions on both sides of the hip joints, and multiple joint involvement. These findings are characteristic of end-stage renal disease, ESRD, with amyloid arthropathy. Differential diagnoses for single joint involvement include synovial chondromatosis and pigmented villonodular synovitis, PVNS. To further evaluate, I would perform a synovial biopsy to confirm amyloid deposition. Management involves addressing the underlying ESRD, often with dialysis, and management of amyloid arthropathy symptoms. Let's move to the next case. What do you see in this image? This image shows severe secondary osteoarthritis with flared metaphyses, widening of the intercondylar tunnel, and dense joint effusion. These findings are indicative of hemophilia with secondary osteoarthritis. Differential diagnoses include juvenile rheumatoid arthritis, JRA. To further evaluate, I would recommend a coagulation profile to confirm hemophilia. Management involves factor replacement therapy to prevent bleeding and symptomatic treatment for osteoarthritis. Let's move to the next case. What abnormalities do you notice in this image? This image shows bilateral hip joint destruction with acetabular remodeling and subtle spinal dysraphism. These findings suggest neuropathic hip joints with spina bifida. Differential diagnoses include congenital hip dysplasia, bilateral femoral head avascular necrosis, AVN, and bilateral septic arthritis, unlikely. To further evaluate, I would recommend an MRI to assess the extent of spinal dysraphism and hip joint destruction. Management involves orthopedic intervention for hip stability and surgical repair of spinal dysraphism if necessary. Let's move to the next case. What do you see in this image? Here I see a cortical lucent lesion with a sharp margin and a thick sclerotic margin without periosteal reaction or soft tissue mass. These findings are indicative of an ossifying, non-ossifying fibroma. Differential diagnoses include fibrous dysplasia, eosinophilic granuloma, EG, and infection. To further evaluate, a biopsy can confirm the diagnosis, but often the clinical and radiological findings suffice. Management involves monitoring, as these lesions typically regress spontaneously. Let's move to the next case. What abnormalities do you notice in this image? This image shows an expansile long lesion of the proximal humerus with bowing deformity and a ground glass matrix. These findings are characteristic of fibrous dysplasia. No differential diagnosis is needed here. It's an Aunt Minnie. To further evaluate, a biopsy can confirm the diagnosis, but typically the radiologic appearance is diagnostic. Management involves observation and treating any symptoms or complications, such as fractures. What do you see in this image? Here, I see multiple expansile lucent lesions of the wrist and digits. These findings are characteristic of Ollier's syndrome. Differential diagnoses include polyostotic fibrous dysplasia, which can also present with multiple lucent lesions, but typically has a more ground glass appearance. To further evaluate, I would recommend a skeletal survey to assess the extent of involvement. Management involves regular monitoring for malignant transformation and orthopedic interventions as needed. Let's move to the next case. What abnormalities do you notice in this image? This image shows a very lucent round lesion in the tuft with a smooth sclerotic margin. These findings suggest a tuft epidermoid. Differential diagnoses include glomus tumor, giant cell tumor of the tendon sheath, and simple cyst. To further evaluate, I would recommend an MRI to help delineate the lesion's characteristics. Management typically involves surgical excision, especially if symptomatic. Let's move to the next case. What do you see in this image? This image shows trabecular and cortical thickening involving the left hemipelvis and proximal femur. These findings are indicative of Paget's disease. Differential diagnoses include sclerotic metastases, but this is less likely given the pattern of thickened trabecular cortex. To further evaluate, I would recommend a bone scan to assess the extent of the disease. Management involves bisphosphonates to control disease activity and monitoring for complications such as fractures or sarcomatous transformation. Let's move to the next case. What abnormalities do you notice in this image? Here, I see pes planus in a skeletally immature patient with an elongated anterior process of the calcaneus, known as the anteater sign. This is characteristic of Osseous calcaneo-navicular coalition. There are no differential diagnoses here. It's an ant mini. An oblique view is diagnostic and confirms the coalition. Management typically involves conservative treatment with orthotics, but surgical intervention may be necessary if symptomatic. Let's move to the next case. What do you see in this image? This image shows similar findings of pes planus in a skeletally immature patient with an elongated anterior process of the calcaneus. This time, it's indicative of a fibrous calcaneo-navicular coalition. Again, no differential diagnosis is needed here. It's another ant mini. The oblique view is diagnostic and confirms the coalition. Management involves conservative treatment with orthotics or surgical intervention if symptomatic. Let's move to the next case. What abnormalities do you notice in this image? This image shows fusion of the lunate and trachetrum. These findings are characteristic of carpal coalition, lunate trachetrum hernia. There are no differential diagnoses here. It's an ant mini. No further investigation is necessary as this is a known congenital anomaly. Management is usually conservative unless symptomatic, in which case surgical options may be considered. Let's move to the next case. What do you see in this image? Here I see a central line from the right subclavian approach terminating to the left of the spine just under the aortic arch. This finding suggests arterial placement of central venous line. Differential diagnoses include extravascular mediastinal location. To further evaluate, I would recommend a chest X-ray or CT scan to confirm the malposition. Management involves immediate removal of the line and repositioning it correctly with monitoring for any vascular complications. Let's move to the next case. What abnormalities do you notice in this image? This image shows a right-sided aortic arch with anterior bowing of the trachea by a soft tissue opacity. These findings suggest a right aortic arch with aberrant left subclavian artery. Differential diagnoses include a double aortic arch and other vascular rings. To further evaluate, I would recommend a CT angiography or MRI to provide detailed vascular mapping. Management may involve surgical correction if symptomatic, especially if there are respiratory or swallowing difficulties. Let's move to the next case. What do you see in this image? Here I see cardiomegaly, dense bones, and possible avascular necrosis of the right humeral head, along with an absent spleen in the left upper quadrant. These findings are characteristic of sickle cell anemia. No differential diagnosis is needed here. It's an ant mini. To further evaluate, a complete blood count, CBC, and hemoglobin electrophoresis can confirm the diagnosis. Management involves regular monitoring, pain management, and treatment of complications such as infections and vaso-occlusive crises. Let's move to the next case. What abnormalities do you notice in this image? This image shows a hyperlucent right hemithorax, inverted right hemidiaphragm, and leftward mediastinal shift. These findings are indicative of a tension pneumothorax. Differential diagnoses for a unilateral lucent lung include Swyer-James syndrome, air trapping from a foreign body, and allogemia from a massive pulmonary embolism. To further evaluate, immediate clinical intervention is required, typically with needle decompression followed by chest tube placement. Management involves continuous monitoring and addressing the underlying cause of the pneumothorax. What do you see in this image? Here I see left lower lobe consolidation with multiple cavities containing gas fluid levels. These findings are characteristic of pulmonary sequestration. Differential diagnoses include necrotizing pneumonia and bronchogenic carcinoma with necrosis. To further evaluate, I would recommend a CT angiography to delineate the anomalous blood supply and confirm the diagnosis. Management typically involves surgical resection of the sequestered lung tissue. Let's move to the next case. What abnormalities do you notice in this image? This image shows hyperinflated lungs with diffuse bilateral bronchiectasis. These findings are indicative of cystic fibrosis. Differential diagnoses include immotile-cilia syndrome and congenital immunodeficiency with recurrent infections. To further evaluate, I would recommend a sweat chloride test or genetic testing to confirm cystic fibrosis. Management involves airway clearance therapies, antibiotics for infections, and enzyme replacement therapy to manage pancreatic insufficiency. Let's move to the next case. What do you see in this image? This image shows extremely hyperexpanded lungs with a basal predominance and enlarged central pulmonary arteries. These findings are characteristic of alpha-1 antitrypsin deficiency. Differential diagnoses include Ritalin toxicity, which can also cause severe hyperexpansion but lacks the basal predominance. To further evaluate, I would recommend serum alpha-1 antitrypsin level testing and genotyping. Management involves augmentation therapy with alpha-1 antitrypsin, smoking cessation, and regular monitoring of lung function. Let's move to the next case. What abnormalities do you notice in this image? Here, I see a veil-like opacity of the left hemithorax, a central left hilar mass, and subtle signs of left-sided volume loss. These findings are indicative of left upper lobe collapse and central bronchogenic carcinoma. There are no differential diagnoses here. It's an ant mini. To further evaluate, I would recommend a CT scan of the chest and a bronchoscopy with biopsy to confirm the diagnosis. Management typically involves surgical resection, chemotherapy, and/or radiation therapy, depending on the stage of the cancer. If you enjoyed these case discussions and want to see more, make sure to subscribe to our YouTube channel, Radiology Made Easy. We cover a wide range of radiological cases across different systems, helping you enhance your diagnostic skills. Don't miss out on our latest videos and updates. Click that subscribe button now.